Welcome to the meeting. I hope you enjoy it and take advantage of all of the faculty during the next day and a half. So I was asked to reveal my age and talk about some of my, it's sort of like a philosophical discussion in a way, thoughts on building a successful career in structural heart disease. And, you know, maybe you need more than 10,000 hours to get it right. So building a successful career can be very challenging. And as I was putting the talk together, I try to sort out exactly what kinds of behaviors or theoretical framework you have to work in to be successful. And it all sort of boils down to what's fairly recurrent in medical literature of 5 A's in medicine: availability, affability, ability, affordability, and accountability. And I'll talk about some of those things which you have to sort of make part of your fabric in order to be successful. Most importantly, you have to always put the patient's interest paramount. This is my grandson. So you have to think in a way, certainly the pediatric cardiologists in a way, if you wouldn't do it to your grandson, don't do it to your patient. Absolutely not. And this is an example of a patient we took to the laboratory. You have to think physiologically, not just anatomically. So you do this and you say, oh, okay, well, no big deal. He's going to have a Fontan. We don't have to deal with that. But then you have to ask yourself the question, why does that happen? Why does this patient have this lesion? And that's because he's got left pulmonary artery stenosis and the pressures are high and he's decompressing down his agassiz vein. Excuse me. This is another patient that we took to the laboratory, ASD, QPQS 1.9 to 1. Numbers look okay. IVC saturation was 63. No big deal. What's the problem? Closed the ASD, but missed the anomalous vein because we weren't paying attention to we were paying more attention to the anatomy and not just to the physiology. I think many of you would have closed that ASD anyhow, but nonetheless it was an undiagnosed issue in the catheter laboratory. And it's easy for the interventionist to say it can't be done or shouldn't be done. This is a patient with discontinuous pulmonary arteries who we stented both PAs, because you have to always remember that transferring our risk of doing a procedure to the surgeon is really not a modality to evolve risk or guarantee risk reduction for the patient in the long term. And just remember that the disease or the natural history or the unnatural history of the disease should be worse than the treatment. So I just want to show you a case, actually a couple cases, that I experienced. We really have to think about how we deal with the management both in the short and the long term. This is a 12-year-old girl that I looked after since she was born. She's much older now, but when this occurred, she had pulmonary atresia VSD, had a TIA.
At 3 days of age, we tried to perforate the outflow tract, but succeeded in only perforating the wall of the heart.
So that was the first thing we did with this child, was try to palliate pulmonary atresia VSD with an RVOT stent. That didn't work, so we went, there's the adventure into the mediastinum. So the child went at 8 days of age for surgery. He had a repair. They left a small ASD. At 1 year of age, the conduit that was implanted became stenotic. So here we are back again, putting the conduit, an RVOT stent in the conduit to palliate the stenosis. Very, very well clinically over the years. Mild RV hypertension, about 2/3 systemic, 93% saturated, but desaturates when she was exercising. Hemoglobin a little bit high, but she wasn't clubbed. I thought it was all related to her shunting at atrial level. Comes into the office, has a history of a TIA. Right hand arm numbness, slurred speech, lasts for about 45 minutes. no prodromal suggestive of a seizure. He had a full neurologic workup, which was fairly benign, and a thrombophilia workup, which was negative. So we do an echo and do a bubble study, and you can see the bubble study is positive. This is shunting at atrial level. Take her to the lab, close her ASD/PFO, treat her so she...
Now I am feeling pretty smart. She must have an atrial level shunt resulting in a right to left shunt in the TIA.
So we take her to the lab. I put a device in her atrial septum. I close her PFO/surgical ASD. Everything looks pretty good. But then I did another bubble study in the lab. Uh-oh, positive. What's going on?
Now I feel really stupid, especially in front of my fellow.
What's going on? Anybody see that? You can't say anything, Allison. You know. Anybody? Unroofed coronary sinus. Yeah. She's 12 years old. She's had that. She wasn't, that breast wasn't blue. All right.
I hope you do not make this mistake. You can avoid it by thinking about the anatomy before the case and do not jump to conclusions that seem obvious. I hope you enjoy the rest of the meeting.
Okay. So remember, in the cath lab, just like in the forest fires, big problems always start small. So this is another case. This is a 3-day-old with double outlet right ventricle, pulmonatresia, ductal-dependent blood flow, on prostaglandins. Surgeons didn't really want to do anything in terms of a shunt, surgical shunt, and they didn't want to do a repair at that time. So we asked, can we stent this shunt? It's like, you go to a barber, you get a haircut. Of course you can do that. Of course. Why not? This is the setup angiography. It's a right arch. Looks pretty good. Sats around 75% on prostaglandins. You can see the duct. It has a sort of a S shape, but not an issue. We decided to go retrograde. Perhaps today we would do it differently, but there's the angiography. We take another picture. Something's not going well. Sats are falling. Anesthesia is going crazy. That's my anesthetist. What should we do now? I'm not happy. It's a nightmare. I call the surgeon. Sats are low. We go on ECMO. This is something pediatric cardiologists do. The adults don't do that too often. Everything stabilizes, so we decide to go in to stent the duct, and we will decannulate in the cath lab. Picture, things are stable. I'm feeling better. Anesthesia is now talking to me. We do all the appropriate measurements. We put the first stent in. It's a little short. We put a second stent in. Looks really good. Everybody's happy. We're starting to feel pretty good about ourselves. Everything seems okay. And then what happens? We have to take the wire out. So what happens when we take the wire out? The wire, which was a backup wire, curled around the distal end of the shunt, and when we pulled it back, not so good. So that was the end of my day. So you always have to have a plan B, or C in this case, and you have to be prepared for things that are not going well. The child was stable, on ECMO, and we were able to deal with it surgically. So you also have to take advantage of the experience of your masters, which is, again, why most of you are here today. Learn from the mistakes of others, because you won't live long enough to make them all yourself. That's the best way to listen to what other people have to say. This is more for the adult cardiologists, because pediatric cardiologists don't pay much attention to the access sites, but if you make a mistake, it's in a different day. That day is very different. So you have to be very careful about simple things, which can lead to lots of problems in the future. And I always tell my fellows, when they enter the program, and when they leave the program, it's much easier to stay out of trouble than to get out of trouble. Very important. So analyzing the facts is important. June 25th, 1876, George Custer decided he received some information that some Indians were gathering around the Little Bighorn, so he decided, without analyzing the facts, without looking at the data, he decided to ride out with 250 soldiers to surround 3,000 Indians. That was a serious mistake. So some other things that more philosophical perhaps about how you manage yourself in a medical environment. Respecting your coworkers is very important. You have to be available. Don't be MIA to your colleagues. Don't be slow to respond to giving advice. To responding to that email a week or two later is not a good way of doing it. And then occasionally, you have to just hold your nose and just do what the referral doctor wants. It's hard sometimes, but sometimes you just have to do that. You have to be affable. You have to get to know the referring doctors. Give them a call with the results of what you've done, even within your own department. And let the referring doc know what the plan is and avoid criticizing what their plan is. Say, well, just do what the guy wants, and that's okay. None of us work in isolation. We have to build bridges. This is a team sport. There's lots of people that are involved in structural and congenital interventions. It's not just the guy pushing the catheter in the catheter laboratory. Don't overestimate your skills. Early in your career, be overcautious. Don't be a cowboy. Ask more experienced people, your partners, for their input on tough cases. Have someone scrub in on with you to help. That's not demeaning. It's very, very important as you build your experience, and meet the families beforehand. I mean, there's the worst thing that can happen, or many bad things can happen, but the worst thing can happen is you have a problem in the lab and you haven't met the family. And then the first time you say, hi, I'm Dr. Benson. I got some bad news for you. We tore the vessel. Your son or your brother or your sister's in the operating room. Not good. This meeting is ask questions. Ask questions. Always question about what you're doing. Don't forget to focus on the child or the adult. It's not just a procedure. I can tell you there's many times when you watch fellows doing procedures, they're looking at the screen, they're turning the catheter while the heart rate is getting slower and slower, the saturation sounds are going lower, and they're not paying attention to what's going on in the environment around you. You only have one chance to make a good first impression. It takes 1,000 cases to make a good reputation. Just remember, it only takes one to ruin it. And I've heard it said the difference between good and great is courage. But to know the difference between courage and stupidity is very important. So, parting words, keep calm and practice those 10,000 hours. And just remember, it's not just the grammar in this saying. The difference between knowing your shit and knowing your shit is important. Thank you very much.